Okay, so obviously with the low subtalar joint axis, more frontal plane, we get a really shallow range of motion, so you get more of a saucer effect. So doesn't it tell you exactly where the axes are, and there are papers written about how you can plot the axis and you can do all this stuff, and you can spend an hour and a half in your clinic doing that if you want. But essentially when we're looking at a clinical basis, we're comparing one foot to the other and getting an idea of where the axis is so that we can be more effectual when we decide to try and change that. Okay. And the range of motion in gait's very small, so we're talking 4 to 6 degrees, and I don't even think they can see that appropriately. So when you watch a person walk, you don't see the heel hit there and go down. A lot of times the movement's that quick and very minor that you won't notice it. So a lot of people look at feet from behind and consider that a perpendicular calcaneus is normal. Would that be fair enough to say? And that's not the truth. It changes with each individual, so that just because the calcaneus is perpendicular doesn't mean that it's operating in its normal range of motion. That makes sense? Okay, because it could be a uncompensated rear foot varus. Calcaneus could have a C shape, could be curved, so it's stuck in an inverted position. To straighten it up, you may cause more damage than you should in that sense, but you may need to accommodate for it. Okay? All right. And so that's the point of the normals is more ideal. It's what we look at rather than actually fact along those lines. Metatarsal joint, that's the one. Subtalar joint, yeah, but this is the one. This is the joint that stuffs us up. You've got a three-dimensional joint. Well, they're all three-dimensional joints, but a really significant three-dimensional joint that we're trying to control with a two-dimensional treatment. So we have more issues controlling the forefoot, and most of the pathology is in the forefoot. You've got your bunions, your hammer toes, your neuromas, your midfoot arthritis, navicular, the ossicles, extra ossicles, a lot of them are around the navicular area. You've got abnormal positioning of the navicular. So a lot of the problems with feet usually are more in the midfoot to forefoot. And okay, you get ankle problems, don't worry. You get ankle sprains, you get injuries, you get broken bones, you get all that. But if we're just talking the basic patient that comes in and says, my foot hurts, 9 times out of 10 it's more likely to be something in the forefoot that's not working that's creating the problem elsewhere. All right. So, how does it work? I mean, bugger if I don't know. It's more of a really weird movement, which is a good scientific explanation for it. It has 2 axes, is what they're looking at. So you've got your oblique axis and your long axis. So the motions that we're looking at is frontal plane and transverse plane. And that's sort of where the metatarsal joint works in. So when you stabilise your rear foot and so when you stabilise your rear foot, you can sort of see that's sort of a pictorial of the approximate axes. Don't take it as gospel, but that's sort of the ranges of motion. So if you've got a higher oblique axis, then obviously you're going to get more transverse motions. And what sort of foot types do you see with those? You see those feet that may not look too bad from the back, but their toes are over there. All right? And they end up with maybe perineal dysfunction or other problems because the medial side's disadvantaged quite dramatically. So over the years you start getting issues. And people talk about then forefoot varus. So when you put your forefoot in a corrected, rear foot in a corrected position, the forefoot is up in the air, can't reach the ground. So let's shove rubber under there and make the ground come up to them, and that'll fix all their problems. No. That may help to solve some of the symptoms because obviously the stresses aren't going down. Now, unless they've got gross, no one's ever proven that there's an osseous or even a congenital issue with the forefoot being in varus, so the big toe being up and the little toe being down relative to development. So a lot of it's more with stress and adaptation over years. So we tend to look at more of a supinatus type effect, so that the actual rotation is more caused by positional change, obviously following up with soft tissue change, ligaments are stretching on one side, muscle tightening. So a lot of times with those feet you'll see they look like they're floppy, crappy feet, but you'll find that the extensor tendons are as tight as buggery. You'll find other muscle groups that are tight, so it creates a bigger problem. But just shoving that part of the foot up into the air doesn't solve the problem, it takes some of the strains off. So then we've got to figure out how we can sort of correct the midfoot to try and bring the forefoot back into alignment, especially the first ray, to try and get that windlass effect, try to get that propulsive effect, because it doesn't do anybody any good walking like that. You know, it's just not a efficient gait, which I think we'll all agree. The major problems with that, then it starts to affect the leg, the knee, etc. I mean, I'm concentrating on the foot because that's where my bag is, but we'll sort of get up a little bit higher a little bit later. So essentially, all those particular control features need to go into the orthoses as well. So just having a rubber arch underneath the middle of it is not going to fully control it or fix it. And that's when you see some people have these things on and their foot will be sort of pushing outside the shoe and they're walking on the side of their shoe like that because the front of their foot can't stay on top of the orthotic because it hasn't been compensated for correctly. So a lot of those mechanisms are relative to prescriptions that aren't quite correct, and that may be because someone's goofed, or it may be because the foot structure just doesn't have the ability to go there, and that means that it may need to have a lot of other therapy as well, mobilisation, soft tissue therapy, sledgehammer, whatever it does take to get it down is what you need to sort of work on it along those lines. But if it's been there for 40 years, it's going to be a tougher job than if it's a 5 or a 6 year old, and trust me, 5 and 6 year olds come in with these problems, and if they're not fixed early they end up with bigger problems when they're older. And they may not be symptomatic, that's the other problem. Just because you compensate and you cope still doesn't mean it's right, okay, especially for the foot. Yep, deviation, motions primarily in the frontal plane. So when you're looking at stabilising it and you're looking at the right foot for argument's sake, we would expect to get the mid-tarsal joint motion to be going pretty much in the transverse plane, going across and then hooking up like a J movement. And that's sort of normal-ish range. It only moves probably about 4 or 5, 6 mil. So it's not a joint. They've got some practitioners that showed me how much motion they're in mid-tarsal joint, and they grab the front of the foot and they go, look, the foot can do this, right? We've got the Liz Franks joint in front of the mid-tarsal joint. If you don't take that out of it, you're not examining the foot properly. You're getting too much motion because you're actually just bending the toes rather than concentrating on the mid-tarsal joint. That's just the position of it. Okay, so when the two axes are more parallel, so if you've got the long axis and the transverse axis with the foot coming, well, as it says, it's more pronated. So if it's operating in that parallel mode, then obviously there's a structural deviation that's creating that problem for that foot, and it automatically pronates. There's no way it can supinate while those axes stay in that parallel position. If the axis is deviated dramatically, then you could get to the point where the mid-tarsal joint's that stiff that it doesn't move, and then that creates other compensatory problems to the foot, and then obviously to the ankle, the leg and the knee later on. That makes sense so far? Yep. Okay. All right. The first ray, which, you know, I don't know what your terminologies are. Every medical fraternity has some of their own terminology for certain areas. But the first ray consists of the first cuneiform and the first met, and basically that is your first ray has the ability to plantarflex and dorsiflex, which allows for that adaptation to the ground, and also for resupination for it to plantarflex to get a rigid foot to take off from, as well as the opposite to dorsiflex and adapt to the ground if the ground's not evenly. So it's the whole structure from really the big toe right up to the navicular that operates around there, not just the first metatarsal joint. And the axis is about 45 degrees, and the reason there is because when you plantarflex your first ray and dorsiflex your first ray, you've also got a degree of rotation. Okay, so how many people notice with a bunion, the bunion doesn't come out there, the bunion goes out and rotates, and that's why the toe turns, then the toe goes across there, and the other toes go across the top, and they look like such a beautiful foot in the end. So essentially, by just lifting or trying to plantarflex the first ray with some form of correction doesn't always, is not as effective as it could be, and a lot of that's because of the adductor weakness as well, so sometimes we need to sort of release or strengthen those muscle groups in combination. There's a couple of techniques that I use on orthotics to try and get that first ray position better rather than just concentrating on a normal just arch supported type of orthotic. So then you start talking about extensions, Morton's extension, Clooney's post, the names go on and on, but the bottom line is that the mechanism is to control the foot and then try and build into that orthotic some sort of degree of ability for the first ray to plantarflex, not just be shoved up in the air because you've got a nice big arch support in the shoe. So that gives you that function back, even with the bunion foot to a degree. How you cure bunions? Again, with a hammer and a chisel, yeah. Right, it's hereditary. Once you got them, you got them. All you can do is slow them down with proper muscle therapy and orthotics. I've never really found a cure yet. I'm still working on it. But the point being is the bunion's probably one of the most common weaknesses in a foot, and I've seen them in athletes, super athletes. I've seen them in little old ladies. I've seen them in kids. I've seen juvenile hallux valgus is probably the worst because they've already set themselves up for a lot of foot and leg issues in the future. So that needs to be addressed properly for full function. Otherwise, the rest of the structures are just working too hard. So first metatarsal joint, it's a ginglymoid joint, which means that you get a little bit of rotation, as I said, as well as a hinge type of effect coming through. The range of motion should be about 75 degrees. So if your big toe doesn't bend back at least 75 degrees, then it's got a range problem, okay? And you'll see feet that you sit them up on the bed and you go, oh yeah, nah, you're fine. Put them on the ground, then try to bend that big toe and see how fine they are. And that's the issue with